Welcome to this video on the Introduction to Toxicology. The objectives of this video include an introduction to toxicology, discussing different routes and categories of poisoning, presentation, assessment, investigations, general and immediate management, and legal considerations. Toxicology is the branch of science concerned with the nature, effects, and detection of poisons, or the measurement and analysis of potential toxins and substances in a person's body. Poisoning can be classified as either intentional or unintentional. Poisoning can occur through different routes, including ingestion, injection, inhalation, transdermal, and others. A high index of suspicion is often required. Emergency department management of poisoning involves initial resuscitation, identifying the agent, providing specific treatment or antidotes, and general supportive measures. Causes of overdose include pharmaceutical products, recreational drugs, industrial chemicals, and others. Pharmaceutical products involved in overdose include OTC medications like paracetamol, aspirin, opiates, benzodiazepines, and antidepressants. Recreational drugs such as alcohol, opiates, cocaine, amphetamines, and hallucinogenics can cause overdose. Alcohol is often co-ingested. Industrial chemicals, household products, and environmental toxins, including inhaled poisons like carbon monoxide, are other causes of overdose. Animal, fish, and insect bites or stings can also lead to poisoning. Signs of poisoning can include a history of attempted suicide or substance abuse. Airway and respiratory symptoms may involve respiratory depression or oropharyngeal burns. Cardiovascular symptoms range from hypotension to cardiac arrest and arrhythmias. Neurological symptoms can include agitation, confusion, unconsciousness, convulsions, or muscle rigidity. Gastrointestinal and renal symptoms like vomiting, diarrhea, and organ failure may also occur. Other features associated with poisoning include hypo or hyperthermia, self-harm injuries, trauma, and electrolyte imbalance, especially metabolic acidosis. Certain poisons are associated with individual signs and symptoms. Clusters of symptoms known as, quote, toxidromes may occur together with specific agents, which will be discussed in later videos. Investigations are guided by the patient's condition and likely causative agents. They may include ABGs, FBC, blood methemoglobin concentration, and RBC cholinesterase activity. Further investigations include U&Es, LFTs, serum calcium, CK, glucose, blood alcohol levels, and paracetamol and salicylate levels. Specific drug serum levels may also be required. Carboxyhemoglobin, urine myoglobin, and toxicology samples should be considered. A 12-lead ECG is important to check for issues like QT prolongation or ischemia. CXR is used if aspiration is suspected. AXR can be useful for radiopaque substances. Head CT or LP may be considered to rule out other causes of unconsciousness. Differential diagnoses include conditions causing altered consciousness, behavior, or respiratory depression, such as head injuries, meningitis, or hypoglycemia. Other differential diagnoses involve conditions causing cardiovascular collapse like anaphylaxis, or muscle weakness, such as Guillain-Barré syndrome. Non-specific symptoms like vomiting or hypothermia also need to be considered. Systemic changes associated with poisoning will be discussed in detail for each type of poisoning in later videos. General and immediate management of the poisoned patient requires rapid simultaneous assessment of the patient and the likely agents involved. Information should be sought regarding the agent, amount, and time of ingestion. This information can be obtained from the patient, family, witnesses, or paramedics. Reviewing repeat prescriptions from the GP and examining pill bottles or tablets is also helpful. Management starts with resuscitation and primary survey. Airway support is critical. Intubation may be required for hypoxia, diminished consciousness, aspiration risk, or ingestion of corrosive substances. Breathing support involves ensuring adequate ventilation and using mechanical ventilation if necessary. Hyperventilation may be appropriate for a short period in extreme acidosis. Circulatory support may require fluid loading to treat hypotension. Inotropes might be needed, but their use should be discussed with an expert, as they may interact with certain drug overdoses. Hypotension from arrhythmias requires specific antiarrhythmic drugs. Correction of hypoxia, acidosis, and electrolytes is also necessary. Profound bradycardia may need early pacing or chemical pacing. Glucagon may treat beta blocker toxicity, and calcium chloride for calcium channel antagonist toxicity. Hypotensive agents may be needed for hypertension caused by stimulants. Neurological support for convulsions involves short-acting benzodiazepines like lorazepam. Be mindful that benzodiazepines may have been part of the initial overdose. Prevention of absorption can involve activated charcoal, 50 to 100 grams, if a toxic dose was ingested within the past hour. Charcoal can be given via NGT if the airway is protected. Gastric lavage is generally not recommended. It is considered only for extreme risk from very toxic substances ingested recently, less than 1 hour. It's contraindicated if there is an aspiration risk or ingestion of corrosives or hydrocarbons. Further management for agitation includes treating underlying causes like hypoxia. Sedation might be needed for profoundly agitated patients, but can worsen hypotension or reduce consciousness. For coma, naloxone or flumazenil can be used as a diagnostic challenge if opioid or benzodiazepine involvement is suspected. Flumazenil should be avoided in suspected tricyclic overdose due to seizure risk. Hypothermia is common after prolonged unconsciousness or with certain drugs like barbiturates. It may require rewarming and can be associated with bradycardia. Hyperthermia is linked to stimulants and neuroleptic drugs. Cooling and specific anti-hyperthermic therapy may be required. Other management includes catheterization, urine output measurement, regular blood sugar monitoring, and invasive and continuous ECG monitoring for many poisonings. Antidotes or specific treatments are available for certain drugs and chemicals. Active removal of drugs and poisons can involve hemodialysis or hemoperfusion for specific toxins. Urinary alkalinization using sodium bicarbonate can promote renal excretion of acidic drugs, aiming for a urine pH of 7.8 to 8.5. Extracorporeal removal of common poisons can be achieved through hemodialysis or hemoperfusion. The management summary includes addressing toxic exposure or poisoning, supportive care, investigations, decontamination, enhancing elimination, and antidotal therapy. Regarding legal pitfalls, deaths from poisoning must be reported to the coroner. Some patients, particularly those who have attempted suicide, may refuse treatment. Mentally competent patients have the right to refuse treatment, even if it risks death. Mental competency requires the ability to understand, retain, believe, and evaluate information. Life-saving treatments can only be administered against a patient's will if they are not mentally competent. If in doubt, seek senior or psychiatric advice early. Document any refusal or treatment against wishes carefully.